Hello, my name is Carole Dennie, and I'm going to speak about imaging of acute pulmonary embolism and chronic thromboembolic pulmonary hypertension. I have no disclosures, and at the end of this session, you should be able to choose an appropriate imaging protocol to obtain a diagnostic CT pulmonary angiogram at the lowest radiation dose, to list the imaging features of acute PE and the diagnostic pitfalls encountered on CT, to summarize the status of CTPA in suspected acute PE and review the guidelines for the diagnosis of suspected PE. Finally, you should be able to describe the CT signs of chronic thromboembolic pulmonary hypertension, or CTEPH. I'll start with a bit of background. Venous thromboembolism is the third leading cause of cardiovascular mortality, accounting for 5 to 10% of all deaths in U.S. hospitals. The incidence increases with age, and most patients have associated comorbidities. But acute PE is very difficult to diagnose clinically. So over the next 30 minutes or so, I will discuss CT pulmonary angiography technique, the CT signs of acute PE, the diagnostic pitfalls encountered on CT, the clinical utility of CTPA, and the diagnostic approach to the patient with suspected acute PE. I'll then discuss the predictors of short and long-term outcomes after acute PE, as well as unsuspected PE and isolated subsegmental PE. Finally, I'll briefly discuss chronic thromboembolic pulmonary hypertension. So let's start with CTPA technique. Depending on the patient's size, it's very important to choose an appropriate KVP to decrease radiation dose. Some scanners offer automatic KVP selection, which is very useful. Generally, a pitch of 0.9 to 1.4 is used. With a dual source CT, a high pitch of 3 can be used as well. Dose modulation is key along the X, Y, and Z axis, and probably the most important thing to reduce radiation exposure is to limit the Z axis coverage. Most scanners now offer iterative reconstruction, which is also extremely helpful in radiation dose management. With regards to the injection protocol, the right antecubital fossa should be targeted for venous access. A high flow rate of 4 to 6 mL is recommended, and a high iodine concentration is also recommended. Generally, the volume of contrast used is approximately 70 cc's, followed by a 40 cc chaser of saline. For bolus triggering and test bolus, which any of these two may be used, the ROI threshold in the main pulmonary artery is around 150 Hounsfield units. Remember to add 5 to 8 seconds after the threshold has been attained if you're using bolus triggering. And the number of seconds that you wait generally depends on the speed of your scanner. You should instruct your technologist to coach your patient concerning breathing technique. The patient should be instructed to suspend inspiration and to avoid a deep inspiration, and especially avoid a Valsalva maneuver. This will ensure that you have homogeneous opacification of the pulmonary arteries. With regards to image reconstruction, thin axial reconstructions are recommended. Some centers may consider overlapping images, and for patients with a larger BMI, thicker reconstructions may be useful to decrease the visibility of noise. Finally, coronal and sagittal reformats should be performed, and they should be around 2 millimeters thick. What are the CT signs of acute PE that you should be looking for? Well, these are quite well known and include a central filling defect on axial images surrounded by contrast. When you have a mural filling defect, this is not seen that commonly, but often occurs at branching points. And if you have a vessel that you're seeing longitudinally and you have a central filling defect along the length of the vessel, this is called the railway track sign. You may have a complete defect when the embolus completely occludes the artery. And remember something that is quite particular to acute pulmonary embolism. In the affected artery, you see a central filling defect. The artery is dilated as compared to the adjacent bronchus. This is a feature that is often seen with acute PE and can help differentiate this from chronic PE. There are also pulmonary parenchymal signs that you should look for. Patients may develop pulmonary infarcts or hemorrhage, and these will appear as peripheral subpleural areas of consolidation. Oftentimes, the center of this consolidation is of ground glass attenuation. The consolidation is triangular shaped with a truncated apex, and when you see this, you should really look at the supplying artery. Here we see a nice railway track sign as evidence of the embolus in the supplying artery. There are, however, many diagnostic pitfalls in CT that you need to be aware of. The first group are anatomical. Veins, hilar lymph nodes, mucus-filled bronchi can mimic acute PE. It's important to know your anatomy so you can differentiate pulmonary veins that may not be opacified due to the timing of the imaging acquisition from pulmonary arteries. Pulmonary arteries always accompany bronchi. Pulmonary veins run alone in the pulmonary parenchyma, and if you follow them centrally, they'll drain into the left atrium. Hilar lymph nodes can mimic a filling defect on axial images. Here we see an apparent filling defect in the proximal right interlobar artery. Here's where your coronal and sagittal reformats can be particularly helpful. We can see here that the apparent filling defect is definitely outside of the interlobar artery and a prominent lymph node rather than an embolus. Mucus-filled bronchi can also be tricky. Oftentimes, a patient may have a CT, in fact, because of acute dyspnea, which can be caused by acute aspiration or acute mucus plugging. Again, you use your lung window and follow that up towards the hilum, and you will see that this apparent vessel that is filled with low-density material becomes filled with air proximally rather than contrast, and so you're going to be able to differentiate that bronchus from an artery. Another group of pitfalls is the technical group. These are relatively common, especially motion or respiratory artifacts. The viewing window width is important, and the slice reconstruction thickness is important. Respiratory artifacts are due to dyspnea. Here we see an apparent filling defect in a segmental artery in the right lower lobe. Again, we have to use our lung window, and here we can see that the vessels, the outline of the vessels is quite blurry, and sometimes you can see a double outline. In these patients, you really cannot confidently call an embolus in that location. The window setting is also very important. If you use a narrow window width, you may mask the presence of a filling defect within an artery. Widen your window width, and this may unmask the emboli within the central and peripheral arterial tree. Slice reconstruction thickness is especially important in vessels that run along the imaging plane. Here we see a 5 mm reconstruction and an apparent filling defect in a segmental artery in the right upper lobe. Thinner reconstructions are extremely useful here because we can see that the apparent filling defect was due to volume averaging with the vessel wall, and there is actually no embolus within this vessel. Coronal and sagittal reformats can be very useful to help with these small vascular structures as well. Finally, the last pitfall is a physiological pitfall that occurs when you have unilateral increased pulmonary vascular resistance due to large pleural effusion or severe pneumonia. This is a great example. You can see in this patient with a moderate-sized right pleural effusion and severe pneumonia in the right lung, there is asymmetric opacification of the right interlobar compared to the left lower lobe pulmonary arteries. Is this because of a pulmonary embolus on the right? Well, in this patient, the effusion was drained and the CT pulmonary angiogram was repeated, and you can see excellent and symmetrical opacification of the right-sided pulmonary arteries. So this is a case of increased vascular resistance on the right with asymmetric perfusion of the pulmonary arteries. Let's now discuss the clinical utility of CT pulmonary angiography. CT pulmonary angiography surpassed VQ scanning many years ago, and there are several reasons for this. The first is because CT pulmonary angiography has several advantages. It's available, it's rapidly acquired, it provides ancillary information about the status of the right ventricle, and provides an alternative diagnosis in many patients, which will explain the patient's symptoms. The latter two clearly are not provided with VQ scanning. The diagnostic performance of CT pulmonary angiography is also very good. Older studies showed a sensitivity and specificity between 83 and 100% and 89 and 97% respectively. But outcome studies are very good. The incidence of pulmonary embolism within 3 months of having a negative CTPA is extremely low, and therefore the negative predictive value of a negative CTPA is extremely high. So the diagnostic approach to the patient with suspected acute PE is as follows. It's very important to use 3 parameters: a clinical prediction rule, the D-dimer, and then only use imaging if required. So many clinical prediction rules have been developed. The Wells score is probably the most commonly used. And the D-dimer is a blood test that can exclude pulmonary embolism in low to moderate pretest probability or Wells score less than or equal to 6 without further testing. So the D-dimer in these patients has a very high negative predictive value with a 3-month thromboembolic risk of less than 1%, just as high as a negative CTPA. However, the D-dimer is not helpful for patients with a high probability clinical assessment because it may be false negative. It is also uncommonly normal in patients with a prior history of DVT or pulmonary embolism, in older patients, especially over the age of 80, and in pregnant patients, especially after a gestational age of 20 weeks. Normal levels are also uncommon in patients with cancer and hospitalized patients. The diagnostic algorithm for patients with suspected acute PE, there are 2 that have been published by the Fleshner Society and the ATS-STR. These are for patients who are not pregnant and those who are pregnant. So for the majority of patients, the Fleshner Society recommendations are summarized here. The clinical decision rules should be used. In patients with a low or moderate pretest probability, a D-dimer is recommended, and if the D-dimer is normal, pulmonary embolism is excluded without the use of imaging. If the D-dimer is abnormal, patients should proceed to CT pulmonary angiography. In patients who have a high pretest probability or Wells score more than 6, they should proceed directly to CTPA without the need for a D-dimer. Now, what about suspected pulmonary embolism in pregnancy? We know that venous thromboembolism is eventually diagnosed in less than 10% of pregnant women who present with concerning clinical features. However, pulmonary embolism accounts for 20% of maternal deaths in the United States, and therefore, it's certainly a diagnosis that shouldn't be missed. The sensitivity and specificity of the D-dimer is lower in pregnant patients. It's often falsely elevated later in pregnancy, and there are even case reports of a negative D-dimer in the presence of PE and DVT, so the D-dimer should not be used to exclude PE during pregnancy. So should we do a CT or not do a CT? Well, this should be discussed with the patient and with the referring physician. One should consider the risk of untreated pulmonary embolism versus the risk of radiation. We know that with the administration of iodinated contrast, there is actually no risk to the neonate. Contrast does cross the placenta, but in a study of 344 pregnant women who received contrast for CT, the thyroxine levels were all normal in their infants. So this is a summary of the practice guidelines published in 2011 in those patients who are suspected of pulmonary embolism and who are pregnant. One should start with whether there are leg symptoms present or not. If they are, then one should follow with a leg vein ultrasound. If leg symptoms are absent, a chest X-ray should be performed, and if the chest X-ray is normal, a VQ scan is recommended because the radiation dose to the fetus will be the same as CTPA, but the radiation dose to the breast will be significantly lower with VQ. In the presence of an abnormal chest X-ray, one should proceed to a CT pulmonary angiogram, and if the VQ scan is non-diagnostic, the next step is a CTPA. Other recommendations for CTPA during pregnancy are to use 100 kVp for imaging acquisition, to use a higher injection rate because of the expanded blood volume, to really concentrate on limiting the Z-axis, so stop imaging at the apex of the right hemidiaphragm, to use lead shields for the abdomen. The use of breath shields after obtaining the SCOUT and ingested barium is optional. So now let's talk about the predictors of short-term outcome after acute PE. Indices of PE severity have been developed, and these are clinical as well as cardiac biomarkers and imaging markers. And these help risk stratify the patient for optimal management. For instance, should the patient be admitted for monitoring? Should we change therapeutic strategies such as use thrombolysis rather than anticoagulation? The first index is the Pulmonary Embolism Severity Index, or PESI score. This assigns a number of points to different clinical parameters. An updated or simplified score has also been developed. And patients are stratified to very low risk up to very high risk, depending on these clinical parameters. Cardiac biomarkers are also useful. Troponin can be mildly and briefly elevated, and brain natriuretic peptide can also be elevated. There are also imaging predictors of CT of PE severity. And the most useful is the right ventricular to left ventricular ratio. When this is over 1, it indicates right ventricular strain. And this predicts a higher rate of admission to the intensive care unit. It portends an increased risk of PE-related mortality. And when the ratio is less than 1, patients have a much better prognosis. So the negative predictive value for death is very high. Other parameters, including the clot burden, many scores have been developed. Canadley is one of them. IVC reflux and hepatic vein reflux, so contrast refluxing in these veins, and septal bowing. These have all been investigated and have been shown to be less useful than the right ventricular to left ventricular ratio. So the European Society of Cardiology developed a model of PE severity, which includes imaging features. These can be seen on either echo or CT. Patients with a massive pulmonary embolus have right ventricular dysfunction, systemic hypotension, and elevated biomarkers, and they have a very high mortality. In these patients, thrombolysis might be considered. In a larger proportion of patients, the PE is submassive, and there is evidence of RV dysfunction on echo or CT, but there are no signs of systemic hypotension, and there are no elevated biomarkers. Here, the mortality is much lower, and as these patients have RV dysfunction, they might be admitted for proper monitoring. Finally, the low-risk patients have no right ventricular dysfunction on imaging, and these have a much lower mortality and therefore might be considered for outpatient therapy. What are the predictors of long-term outcomes after acute PE? Again, we have clinical, serum biomarkers, and imaging markers. As far as clinical markers are concerned, there's an increased long-term mortality in older age patients, patients with comorbidities, and those patients who had their PE treated in hospital. Interestingly, 40% of the deaths are due to cardiovascular disease and only 5% are due to recurrent venous thromboembolism. These patients also have an increased risk of developing CTEPH. Again, troponin T and brain natriuretic peptide, when these are elevated, these portend a poorer long-term outcome. And the most useful imaging marker has been shown to be clot burden for long-term outcome. And these patients have been shown to have an increased risk of CTEPH. Other parameters, including the right ventricular to left ventricular ratio and septal bowing, have been shown to be less useful. So now let's talk about unsuspected pulmonary embolism. The prevalence is 2.6% of CTs. And we find that at least 25 to 50% of these are missed on the initial CT examination. Patients who are at increased risk of having unsuspected PE include those with malignancy, especially if it's advanced or they're on chemotherapy, and those who are hospitalized at the time of imaging. The rate of complications and the rate of recurrent VTE and the rate of death are similar to those with symptomatic PE. And as a result of this, the ACCP guidelines still recommend the same treatment for unsuspected pulmonary embolism as those patients with symptomatic PE. The story is different with isolated subsegmental PE. We have seen, since the use of CT pulmonary angiography has increased over the years, we have seen an increase in the number of PE diagnosed. However, if you look at the mortality, this has remained completely stable since we've started using CT pulmonary angiography. However, the case fatality rate has decreased significantly in the same time period. What does this mean? Well, a systematic review of the literature showed that the proportion of isolated subsegmental PE has actually increased from 5 to 10%. And the additional cases of pulmonary embolism might be associated with a lower severity of illness. A randomized control trial comparing the utility of CT pulmonary angiography and VQ also found a greater number of pulmonary emboli diagnosed with CT pulmonary angiography than VQ scanning. And the rate of venous thromboembolism at 3 months was identical in untreated patients. So the authors concluded that the additional PE cases on CT pulmonary angiography might be clinically unimportant. And if we look at meta-analysis of those patients who had no DVT and had isolated subsegmental PE, some of the patients were treated and other patients were not treated with anticoagulants. And if we compare the major bleeding rate, there was a bleeding rate of 7 and 8% in those patients who were treated. In the patients who were treated and not treated, there was no recurrence of pulmonary embolism and no evidence of fatal PE in those patients who did not receive any kind of treatment. So this brings us to the conclusion that the management of single or multiple subsegmental pulmonary emboli in the absence of deep venous thrombosis is controversial. And the risk of anticoagulation may actually outweigh the risk of pulmonary embolism. And so what are the current guidelines recommending? Well, the ACCP guidelines published in 2011 state that isolated subsegmental PE in patients with no proximal DVT who have a low risk for recurrent venous thromboembolism, they suggest clinical surveillance over anticoagulation with a grade 2C recommendation. The European Society of Cardiology in 2014 stated that individualized decision about anticoagulation therapy in patients with isolated subsegmental PE and negative leg vein ultrasound should be considered. So again, these guidelines only apply to those patients with isolated subsegmental PE and no proximal DVT. So this concludes the portion on acute pulmonary embolism, and I hope you found this particularly useful. And now I'm going to turn my attention briefly to chronic thromboembolic pulmonary hypertension. And I'll start with a bit of background. Now, chronic PE develops in up to 3.8% of patients following an episode of acute PE. It's felt to be due to the incomplete resorption of emboli with organization of these emboli into fibrous tissue that is then incorporated into the intima of the pulmonary arteries. And this leads to a distal arteriopathy that develops in both the obstructed and the non-obstructed vascular bed. Now, up to 75% of patients provide a history of venous thromboembolism, and there are associated factors of which thrombophilic disorders are the most important. Interestingly, splenectomy is also an associated factor. So there are certain findings of CTEPH that you should be aware of. Firstly, the patients develop pulmonary hypertension, so you're looking for cardiac features of pulmonary hypertension on CT. Then you must turn your attention towards the pulmonary arteries, and finally there are pulmonary parenchymal findings on CT. So the cardiac features of pulmonary hypertension include right ventricular hypertrophy, so the right ventricular wall is more than 4 millimeters thick. The right ventricle is larger than the left ventricle. The right atrium is dilated due to tricuspid valve regurgitation, and the interventricular septum is straightened. And you may even see interventricular septal bowing, as shown here. The arterial features include dilatation of the main pulmonary artery, more than around 30 millimeters. And the vascular features that you should be looking for include mural filling defects as compared to acute PE, where you're looking more commonly at central filling defects. You're looking for complete occlusion of the arteries, and note that when these are occluded, they taper rapidly. They are not dilated. And then you're also looking for subtle bands or webs and evidence of beading, as shown here. Collateral systemic supply also often develops in these patients, and the bronchial arteries are dilated and just trying to supply the obstructed vascular bed. Parenchymal features are important, so you're looking for mosaic perfusion. This is more commonly seen in patients with CTEPH than in patients with other causes of pulmonary hypertension. There are areas of decreased parenchymal attenuation. In these areas, the vessels are small. In the areas of increased pulmonary parenchymal attenuation, the vessels are larger. You may also see evidence of scarring from prior infarction, so peripheral, linear, or triangular shaped opacities. And so these are the typical features of CTEPH. Now, it's very important to make the diagnosis of CTEPH because this can be cured with surgery. The surgical procedure is called pulmonary thromboendarterectomy. It's done through a median sternotomy with episodes of hypothermic circulatory arrest. And a large proportion of the patients are actually surgical candidates. And they are surgical candidates if the filling defects are identified at or proximal to the proximal segmental pulmonary arteries. The mortality for the surgery is quite low in experienced centers, and their survival after endarterectomy is very good. And this is an example of the endarterectomy specimens that are removed from the pulmonary arteries. Now, it's important to know the role of ventilation perfusion scanning in patients with CTEPH. It really plays a pivotal role. The CT findings can be very subtle in patients, especially when the disease is very distal. And so a ventilation perfusion scan should be performed in all patients suspected of CTEPH because a normal VQ really excludes the presence of this disease. And these are the typical findings that you're looking for on VQ scanning. You see multiple mismatched perfusion defects and a normal ventilation scan. So I'd like to leave you with a few take-home messages. Number one, a rigorous CTPA technique is necessary to achieve a diagnostic study with the lowest radiation dose possible. Be aware of the diagnostic pitfalls on CT pulmonary angiography. And finally, chronic thromboembolic pulmonary hypertension can be cured with surgery, so it's a very important diagnosis to make. Thank you for your attention.